Before you watch this tape on managing wandering and inappropriate sexual behaviors, be sure you have viewed the introductory tape, The ABCs of Behavior Management in Dementia, tape number 3 in this series. It's very important that you understand the method of observing behavior that is introduced there before you proceed through the rest of this tape or the tapes that follow. Here is a quick review of using the ABCs to manage behavior. A stands for antecedent. The antecedent is what triggers a behavior. B stands for behavior. This is the behavior you want to change. C stands for consequence. The consequence is what happens as a result of the behavior. First, you identify a behavior, one that you can see. Write down what the behavior is on a sheet of paper. Next, you record how often the behavior happens. What happens immediately before the behavior, the antecedent, and what happens immediately after the behavior, the consequence. You continue to record this information until you begin to see a pattern. This may only take a few days for behavior that happens often, or longer for a less common behavior. You then change either the A, antecedent, or C, consequence, maybe even both, to break the ABC cycle and change the behavior. Changing behavior is not easy. It takes time and effort. The scenes we show are short in order to teach you how to observe and use the ABCs. But in real situations, things take longer and often take several different tries before you see any change. Be patient and keep trying.
All right, all right.
I gotta find the bus station.
Oh, I see, okay. Oh, she took off again. I better go get her.
Alice? What are the ABCs here? Although it appears that this behavior happens out of the blue, the ABCs can be detected. What is the B, behavior? It's the patient wandering away. What is the A, antecedent? In this case, it looks like there is no A, antecedent. No one approached the patient and nothing really happened. But if we think about it, the behavior really did not happen out of the blue. The A, antecedent, was the patient walking down a dark hall. And we can see from her glasses and hearing aids that she has vision and hearing problems. She could become confused in the hall with no people around for her to hear or to help orient her. So she wanders off to find the bus home. What is the C, consequence? The consequence is that the caregiver pursues the patient, talks with her, brings her back, and tries to comfort her. Let's look at a continuation of this scene, but this time the caregiver will be better prepared because she is paying attention to the antecedents for the patient's wandering behavior.
Hi, Alice. May I walk with you?
Who are you?
I'm Sally. I like to walk too. Alice, do you like muffins? I think there are some fresh baked muffins in the dining room. Shall we go see?
What were the ABCs here? The B, behavior, is the patient wandering. The A, antecedent, is the same as in the previous scene. Decreased light and no activities to help orient the patient triggered her wandering. The C, consequence, is the caregiver joining the patient, speaking with her to help her understand where she is, and calmly redirecting her to another activity to prevent her from wandering away. Once again, the caregiver responded in warm, caring ways to the patient. This is probably good and will probably help the situation in the short run. But what about in the long run? If you look closely at the C, consequence, part of each behavior, you will see that the patient received warmth and attention for displaying a disturbing behavior. When disturbing behavior is rewarded, it will most likely happen again. What can be done so that these situations will not happen over and over again? As was mentioned earlier, in order to change some behaviors, the best place to start would be with the A, antecedent to the behavior. Trying to change the A, antecedent, may prevent the behavior from happening again. That way, you can save your support and attention for when the patient is cooperative and behaving well. To prevent the patient from wandering in the future, try to change the A part of the sequence. The patient may wander less if she gets attention before she wanders. She may also wander less if there are things to help orient her. The wandering, demented person poses problems for safety and often poses a great deal of worry for caregivers. As we said earlier, even though it may seem that there is no A, antecedent, behavior does not happen out of the blue. Some possible antecedents to wandering are sensory overload. Decrease noise and distractions to lessen sensory overload. Remove things that might suggest going outside, like coat racks, coats, and purses. Similarly, sensory underload can also trigger wandering. For example, if the lighting is poor, you can increase the light. Orient the patient with familiar activities and objects. Increase activity and exercise. Stay calm and use good communication skills to make the patient comfortable. An inability to express physical discomforts, such as hunger or a need for toileting, or a room which is too hot or too cold, may increase wandering. Changing these antecedents will help decrease wandering. Coping with wandering is the same as coping with any other behavior. By identifying the ABCs, you can develop a plan to change it. In all things you try, remember, safety is very important. Some common safety checks include night lights, door locks or alarms. Stop signs on doors help some patients. Having a safety plan, which may include having a current picture of the patient or a plan for notifying the police if the patient is lost. Always have the person wear an ID bracelet with their name and who to contact for help. Physical restraints should be a last resort. Providing a safe place for the patient to wander or preventing the wandering by changing the antecedents are better solutions. In the next scene, we will look at issues surrounding patient sexuality, inappropriate sexuality, and how to work with these emotionally charged issues. In this scene, the caregivers will be working with a patient who is behaving sexually at an inappropriate time in front of others.
Look, Jerry's at it again. It's your turn to tell him to knock it off.
Jerry, shame on you. You know you're not supposed to do that in public.
Leave me alone. Leave me alone. Leave me alone. I miss her.
What were the ABCs in this situation? The B was sexual behavior. In this situation, masturbation, which was inappropriate because it was in public. The antecedent, A, was the patient off by himself. The consequence, C, was that the caregiver criticized and corrected his behavior, and Jerry started to cry. Let's look at an alternative intervention and then discuss possible antecedents, consequences, and solutions for inappropriate sexual behavior.
Renee and Freddy, join us. And now, gentlemen, may we see the next item up for bid? A new dishwasher.
Jerry, hi. You want me to take you up to your room?
No, I'd rather stay here.
Will you hold on to these cards for me then, please?
Innovative design, high performance, confirmador. And I stand corrected. Check game was not one. You told me that we'd had 4 wins in a row. Well, no, we have only 3 wins in a row.
Yeah, that's great.
If we have this, now let's see. We've had 2 wins.
What were the ABCs here? The B, behavior, was the patient masturbating in public, which is inappropriate. The A, antecedent, was the patient being off by himself. The C, consequence, was the caregiver distracting the patient with the cards, which keeps his hands occupied, so he stopped masturbating. Notice that the consequence part of the ABCs was handled differently and led to a pleasant resolution of the problem. Instead of having the patient upset and crying, he is busy and involved with the cards. Since the caregiver knows the antecedent, leaving the patient alone and having his hands unoccupied can lead to masturbation, he can take steps to be sure the patient doesn't get left alone and unoccupied at these times, and possibly avoid the behavior in the future. Watching demented people being sexual can be disturbing to others, such as family or other care providers. Self-stimulation or sexual involvement with another person can be a positive and natural event. But if the sexuality involves unwelcomed approaches to others, then steps to prevent the behavior may be necessary. Sexual behavior is not, in itself, bad or wrong. It is the public display that can upset or embarrass people. And certainly, if it is abusive or without consent, it can be harmful. If you happen across a patient masturbating or being sexual in a common living area, provide an opportunity for them to move to a private place or redirect them to a different activity. Once again, you may think this behavior happens out of the blue, but by observing what happens before the behavior, you may find the triggering event. Sometimes in looking for triggering events, you find repeating patterns. For example, you may have a patient who misinterprets bath time and pinches whoever is bathing them. Perhaps a different bather or a different posture will not get that same response. Perhaps the patient interprets hugs as sexual, although you did not mean that. Be careful not to hug this particular patient. There are other ways to touch them, such as a light touch on the arm or shoulder. Similar to wandering, sometimes patients just need more exercise and activity. Redirecting their attention and distracting them may help prevent problems. Keeping the patient's hands busy also helps. Even though you may feel embarrassed by a patient's sexual behavior, it is important that you do not overreact, demean, or humiliate the person. The behavior, even though disturbing, is not intended to disturb you. Overreacting can cause the patient to become agitated or aggressive. This is true for many behaviors. Sometimes you may be able to set limits by telling the patient that his or her behavior bothers you or that you don't like it. Saying no or stop in a firm, clear voice may help. Remember, doing this just once won't help. More likely, you will have to do this a number of different times before you see some effect. Sometimes saying no provokes more resistance from the patient. You can always try to redirect the patient with another activity or leave the situation for a while. In order to encourage patients to use good or non-disruptive behaviors, be sure you praise them when they are behaving in ways that are cooperative and pleasant. This will reinforce those good behaviors and make it more likely that they will reoccur. In the tapes that follow, we will show you other difficult behaviors and how these behaviors can be observed, broken down into ABCs, and changed.